and good night for time differences. There's people, I think, from all over the world. Welcome to our presentation. We started a little late for technical reasons, and thanks to attendees and also thanks to Memorial Health Group to organize this meeting. I'm a neurosurgeon and my specialty is functional neurosurgery, which is restore the quality of life. What we do is basically electricians of the brain. That means we apply electrical methods to modulate the brain circuits in such diseases. Today, we will focus on deep brain stimulation in movement disorders with up-to-date information. In the first part of this symposium, we will mention about the diagnosis and therapy options of movement disorders. In the second part, how DBS performed and what kind of problems we can have and how we can solve them will be our main topics. We have just 1 hour to talk everything, and at the end we will finish off with a question and answer session. For questions, please use the common parts. We can answer all the questions at the end of the presentations if we have enough time. And now I would like to present Dr. Dilek. She's the professor of neurology in our hospital, and we'll talk about movement disorders and selection of patients for deep brain stimulation. Please, Dr. Dilek, screen is yours.
Thank you, Gülşah, for this kind introduction. I will share my screen now. Hello, everyone. Deep brain stimulation is an effective surgical therapy for well-selected patients with medically intractable Parkinson's disease and essential tremor. It's a promising application in dystonia, Tourette syndrome, and epilepsy. Today, I will talk about mainly DBS for Parkinson's disease and a few words about usage for essential tremor. Parkinson's disease is the second most common neurodegenerative chronic progressive and disabling disorder and affects almost 6 million people worldwide. The English physician James Parkinson first characterized Parkinson's disease in his 1817 monograph, An Essay on the Shaking Palsy. One of the cornerstones of treatment is Kotzia's discovery of Levodopa improving symptoms of Parkinson's disease. Then, dopamine agonists, MAO-B inhibitors, and COMT inhibitors found a place in the therapeutic arsenal. And finally, surgical treatments for disease symptoms that were resistant to optimal medical management were also developed. Parkinson's disease incidence is 160 people per 100,000 and men at higher risk than women. Premotor symptoms are defined as symptoms that predate motor symptoms of Parkinson's disease and include constipation, anosmia, REM sleep behavior disorder, and depression. The four cardinal symptoms of Parkinson's disease are tremor, rigidity, bradykinesia, and postural instability. Tremor is often the first motor symptoms of Parkinson's disease and affects approximately 90% of patients at some point in their illness. Tremors start asymmetrically and are characterized by supination and pronation or pill rolling, eventually affecting the opposite side of the body. Tremors may be less responsive to pharmacologic treatment, including L-Dopa. Rigidity refers to stiffness or resistance of a limb when it's flexed passively, activating both agonist and antagonist muscles, and may also be referred as cockwailing. Bradykinesia refers to slowness of movement and may occur during both initiation and continuation of movement. Postural instability or balance dysfunction is experienced later in the course of the disease. Postural instability is elicited by the pull test, and it's a levodopa-resistant symptom in contrast to bradykinesia, rigidity, and tremor. This is a normal pull test. The evaluation of postural instability is important because severe gait problem with prominent postural instability is a relative contraindication to surgery. The secondary motor symptoms are diminished arm swing, decreased blink rate, masked faces, decreased voice volume, and difficulty turning over in bed. There are some non-motor symptoms of Parkinson's disease, neuropsychiatric symptoms, cognitive symptoms, dysautonomia, sleep disorders, and sensory abnormalities. When considering a surgical treatment of Parkinson's disease, having a high degree of diagnostic certainty is important. But the diagnosis of PD may be complex, and it is estimated that 25% of patients have been misdiagnosed with another disease. This is because PD remains a clinical diagnosis. Its diagnosis depends on asymmetric symptoms of resting tremor, bradykinesia, and rigidity, and favorable response to dopaminergic therapy. Atypical Parkinsonian syndromes, such as multiple system atrophy and progressive supranuclear palsy, can mimic Parkinson's disease in their early stage in both symptoms and Levodopa responsiveness. Outcomes of reported cases of DBS for atypical Parkinsonism have been poor, with transient improvement at best and rapid decline in most patients. As a result, with rare exception, a 4-year disease duration is considered a minimum for surgical intervention to help ensure diagnostic accuracy. Red flags for Parkinson's disease are severe dysautonomia, early speech difficulties, early hallucinations, lack of tremor, symmetry of symptoms, poor response to levodopa, dementia preceding motor symptoms, imbalance, postural instability, and freezing within the first 3 years after diagnosis. Levodopa is the gold standard for dopamine replacement therapy in Parkinson's disease. It is administered with a dopa decarboxylase inhibitor, carbidopa, to reduce its peripheral breakdown and lessen nausea. Levodopa is particularly effective in treating akinesia and rigidity, with more variable effects on tremor. No ergodopamine agonists are used as both monotherapy and adjunctive therapy. In the treatment of Parkinson's disease, they have longer half-lives than levodopa, but also have higher incidence of psychiatric side effects, including hallucination and impulse control disorders. COMT inhibitor, sorry, I will, a technical problem. I want to restart my presentation. Sorry for this technical problem. Non-ergodopamine agonists are used as both monotherapy and adjunctive therapy in the treatment of Parkinson's disease. They have longer half-life than L-Dopa, but also have higher incidence of psychiatric side effects, including hallucinations and impulse control disorders. COMT inhibitor reduce the breakdown of L-Dopa and increase the plasma half-life of levodopa and its area under the curve. Rasagiline, a second-generation MAO-B inhibitor, may be used as monotherapy and adjunct therapy. Safinamide is another potent reversible MAO-B inhibitor that has been recently approved as adjunct therapy in patients with Parkinson's disease with motor fluctuations. Amantadine is an NMDA receptor antagonist and has antidyskinetic properties. As Parkinson's disease advances, the reduced storage and release capacity of endogenous dopamine can lead to the shortened duration of L-Dopa benefit. Patients will experience a decline in medication efficacy, in which symptoms return prior to the next dose, referred to as predictable wearing off. Abnormal involuntary choreiform movement that may affect the limbs, head, and torso. Levodopa-induced dyskinesia may also manifest with ballism, myoclonus, dystonia, or a combination of these movements. Dystonia refers to involuntary prolonged muscle contraction with abnormal postures, usually in the limbs. Patient may experience toe curling or foot inversion. Motor fluctuations refer to off times, then full response to L-Dopa alternates with on time. Motor fluctuations occur with advancing disease. If these motor complications cannot be controlled with medical therapies, this may suggest the need of a surgical intervention. Motor symptoms of Parkinson's disease are typically managed with dopaminergic agents for several years. However, as the disease progresses, maximum medical management often proves inadequate because of development of medication refractory symptoms, motor fluctuations, and medication-induced side effects that limit further efficacy. And surgical therapy is developed for this group of patients. As I said earlier, having a high degree of diagnostic certainty is important for surgery indications. And moderate to advanced PD, L-Dopa responsive symptoms like motor fluctuation, dyskinesia are other indications. Per consensus opinion, clinicians may consider surgery for patients with motor fluctuations characterized by disabling off periods and functionally independent on periods. Traditionally, DBS surgery has been performed on patients with advanced PD. However, there are studies about early application. Early STEAM study compared DBS to best medical treatment alone, and DBS performed early in the course of the disease had significant benefits on the primary and secondary outcome of measure. In addition, the investigator found a significant reduction in L-Dopa-induced motor complication in the DBS group. But there are several questions about early DBS. DBS has been proven to be effective up to 10 years. After 10 years, risk of repeated surgical intervention caused by hardware failure and unavoidable pulse generator changes increase with every year. Advancement in technology, such as the rechargeable DBS system, may help us overcome these issues. But other problems to consider are neurocognitive and psychiatric side effects of DBS. L-Dopa responsiveness is one of the most important criteria for surgical intervention. To assess L-Dopa responsiveness, medical history should be taken carefully. Patient must be examined serially and self-reporting tools should be used. An improvement at least 30% on the UPDRS scale is a common minimum cutoff for surgery. In general, levodopa non-responsive symptoms are not expected to improve with surgery, with the exception of tremor. The most notable contraindication for surgery in PD is dementia. Severe gait problem and postural instability, presence of atypical Parkinsonism, unstable psychiatric disease are other contraindications. Many centers consider 75 years of age or even slightly older to be an approximate upper limit. Any medical comorbidity that carry risk of hemorrhage, infection with delayed wound healing or cardiovascular complications should also be carefully considered. All potential surgical candidates should be evaluated with comprehensive preoperative neuropsychological testing to assess risk, guide management, and counsel patient. And psychiatric evaluation is mandatory. Imaging with MRI is necessary to identify strokes, atrophy, or other abnormalities that could interfere with successful lead placement. Clinician must carefully assess patients' expectations and priorities for surgery. One strategy is to ask the patient their top 3 reasons for DBS and then discuss whether or not each reasonable expected outcome for DBS. If an individual is most disabled by non-motor complaint or symptoms that do not respond to L-Dopa, the surgery is less likely to improve quality of life regardless of motor benefits. In conclusion, if there is no suspicion of atypical syndrome, no dementia or significant cognitive impairment, and no prominent gait symptoms, and there is motor fluctuation or dyskinesia with 30% improvement in motor disability scores with L-Dopa, and the patient have realistic expectations for DBS without high-risk medical comorbidity, then patient is a possible candidate for DBS. Essential tremor is the most common movement disorder in the Western world, characterized by bilateral, often asymmetrical action tremor in hands, forearms, head, and voice. Minority of patients have medically intractable disabling tremor. For this patient group, successful tremor control with DBS of ventro-intermedial nucleus of thalamus is possible. Unilateral DBS for limb tremor is enough, but for head and voice tremor, bilateral DBS is necessary. Thank you for your attention.
Thank you very much, Dr. Dilek, for this excellent presentation. And let me share my presentation here. And is there any problem for the technical things? Okay. Take a walk in history of surgery in movement disorders. It began in the 50s with ablative procedures like pallidotomy and thalamotomy. With the introduction of levodopa in the treatment of Parkinson's disease, the need for the surgical intervention declined rapidly. Almost 30 years ago, Benabit et al. Have written long-term suppression of tremor by chronic stimulation of the VIM. They revealed that reversibility and adaptability, along control of side effects, make thalamic stimulation preferable to thalamotomy, especially when treatment of both sides of the brain is needed. Then the legend begins. Given its relative safety, therapeutic efficacy, and reversible and adjustable nature, DBS has become a mainstream surgical procedure over the last 3 decades. To date, it's estimated that over 150,000 patients have been implanted at over 700 centers worldwide. In this pie chart at the right side, the blue one is for movement disorder clinical trials in the world, and the others are psychiatric disorders, cognitive disorders, pain, and the others. In which movement disorders can we use DBS? As Dr. Dilek mentioned before, Parkinson's disease, essential tremor, and dystonia are the most commonly used disease. And when we are searching to do last thing in rare disorders, we can think about DBS in these rare movement disorders. But it's just palliative. First of all, I should say that the success of the therapy relies on these main factors. The first one is the appropriate selection of patients. Dr. Dilek told us many tricks about selection period. We should remember that we are in a team with psychiatry, neurosurgery, and neurology. The second one is accurate placement of the DBS lead in the sensor-motor regions of the target nuclei. We must have sufficient technological equipment and experience while performing DBS. And the third one is programming, and it is necessary factor in the patient's follow-up. And the last one, but maybe the most important one, is reasonable expectations of patients and their family. When we look at the targets of movement disorders, historically GPI has been the preferred target, especially since pallidotomy back in 90s. Following several physiological studies, the investigators become more interested in subthalamic nucleus. When you look at the literature back in time, suddenly there was a shift of the studies that shows improvement of symptoms with subthalamic nucleus target. So the people were more interested in subthalamic nucleus, and GPI was almost forgotten for a while. But there were clinicians who has experienced lesion therapy and DBS. They were not really convinced STN is superior, and they start to study both of targets. And I had my functional neurosurgery training in such a center, and I'm more prone to use GPI target. Subthalamic nucleus and GPI are the most used targets in PD, as I said before. And VIM is the most used one for ET, and GPI is most used one for the dystonia patients. When we look at the targets of Parkinson's disease, both targets have benefits for patients, especially on motor symptoms. Both targets provide long-term benefit on bradykinesia, rigidity, tremor, and reduction in off time. Is written in large-scale studies. And especially for tremor, evidence from all available randomized trials demonstrates no difference in eventual resting tremor suppression across targets, STN or GPI. And which DBS target should I select? This is an ongoing discussion of the best target continues in the field, and this slide is from a recent review of the current literature. When we look at the STN side, it can facilitate the reduction in dopaminergic medications, but in GPI we couldn't do it like STN. Potential increased risk of cognitive and mood decline in STN, and possible increased risk of falls. And greater programming complexity. It has potential economical advantage and potential mild non-motor domains. When we look at the GPI side, possible greater benefit in dyskinesia and greater flexibility for medication adjustment and simpler programming strategies in GPI and better battery consumption and potential for adequate control of symptoms with unilateral implant. If we can do just one side, we can use GPI. And potential benefits in gait. Here you see there are some possible effects of both targets. That means we need more randomized studies for that things. When should we consider subthalamic nucleus? If the patient has side effects from medication and needs to lower the dose, then just subthalamic nucleus. Subthalamic nucleus has a little earlier effect on tremor, but there is no significant difference in first-year control in many studies. And it is the also economically, because less power was consumed in subthalamic nucleus stimulation and less battery replacement was required. But as rechargeable batteries become commonplace, battery life may become less of a concern. And where should we think GPI? Cognition and psychiatric problems at baseline. Speech problems at baseline, severe dyskinesia or dystonia, and mild gait and axial symptoms. As Dr. Dilek said, there are some red flags in the severe symptoms of gait and axial symptoms or cognition and psychiatric problems. But in the mild symptoms, we can just consider GPI. These problems can be worsened with subthalamic nucleus. For example, for dyskinesia, unlike GPI DBS, optimal benefit from subthalamic nucleus DBS often requires greater medication reduction to minimize and manage the dyskinesia. In general, when actual symptoms are responsive to dopaminergic medications, they are likely to improve with DBS. And we should be aware of postural instability, which can affect gait, is less likely to respond to DBS. When it comes to essential tremor, we should talk with the patient these main lines, especially the first sentence. DBS doesn't cure tremor. It can improve the activities of daily living and quality of life, but may not eliminate all tremor types. And sometimes tremor worsens with aging, and vocal and head tremor may be difficult to eliminate with one-side stimulation. Some DBS settings may cause dysarthria or ataxia, and we can use as a target thalamus, VIM, posterior subthalamic area, or zona incerta. But the optimal target for neuromodulation remains unclear for ET, as some centers have adopted the transition to posterior subthalamic area DBS, whereas the others still favor traditional VIM DBS. As I said before, VIM is the traditional target for ET and is known with tremor control. Unilateral VIM DBS provides substantial contralateral and modest ipsilateral tremor suppression and has been shown in select cases to be sufficient for management of axial tremors in ET, but in select cases. And how much improvement should the patient expect in essential tremor symptoms? Although DBS typically provides substantial tremor suppression for most ET patients, long-term efficacy has been variable, unfortunately. In this table, you can see tremor improvement percentages are changing between 20s to 90s in the long-term follow-up. This is an expert study from Florida. They confirmed that dysarthria, ataxia, and gait instability are common adverse effects of essential tremor DBS that are more frequent after bilateral than unilateral procedures and may result from both microtonomotomy effects and from stimulation-induced side effects. The main problem with DBS in ET is loss of long-term efficacy. They have written in this article, it's not uncommon and is due to primarily to the disease progression rather than to tolerance or habituation. We know VIM historically target for ET and many of us using this target still. But in these days, as I said before, posterior subthalamic area and zona incerta are novel and effective targets, but may be associated with more stimulation-induced ataxia. Comparisons between the VIM and STA for ET has been ongoing deliberation. When we come into DBS in dystonia, what's the inclusion and exclusion criteria for DBS in dystonia? Actually, there is no validated criteria for DBS indication. We just know DBS doesn't cure dystonia, as I said before, for the Parkinson's disease and essential tremor. Sometimes symptoms progress despite therapy, may be less effective for secondary generalized dystonias, and may not improve speech or swallowing. But it can improve activities of daily living and quality of life, and it could be more better outcomes in younger patients and may improve pain in cervical dystonia. And effects of stimulation are not immediate. Motor scores gradually improve in over weeks to months. We should wait. How much improvement should the patient expect in dystonia symptoms? Genetically identified DYT1 mutation type is perhaps the most responsive one. It's up to 19% decrease in the Berg-Van-Marsden dystonia rating scale after 12-month follow-up. Studies suggest an average 50% improvement in motor scores for generalized dystonia and 60% improvement for focal segmental dystonia has been written in the literature. When we look at the timeline for the DBS, the procedure of the DBS starts with a careful patient selection, continues with the inpatient period involving surgery and then activation of DBS. The next period is the outpatient period involving further programming of the therapy and further adjusting the drug therapy. And the outpatient period never ends unless the therapy stops. We want to see the patient in balance between drugs and stimulation. When we come to methods of DBS surgery, there are many variations of methods, like asleep, awake, with or without MER, microelectrode recording, with frame or frameless, and with perioperative or without preoperative imaging. There are studies supporting each of these different methods. For example, while some groups find microelectrode recording unnecessary and risky, for some groups it's a must-have method in DBS. Actually, all of them try to provide confirmation of the target anatomically or physiologically to feel comfortable in the OR with the patient. In summary, the DBS surgery is implanting one or more small wires on the frontal area in the brain during surgical procedure. The leads receive mild electrical stimulation from a small pulse generator implanted in the chest, as you see in the picture. I just want to tell how do we do DBS in our center. In summary, we can divide the process into two main sections: before operating room, in the operating room. Before the operating room, the coordinates determined for the safest trajectory to the specified target. First of all, we take and retest a cranial MRI with 1 millimeter thickness before the surgery. This imaging should be done recently. We find it more appropriate to do it one day before the surgery. Being immobile during MRI is one of the most important factors in terms of accuracy. We can do it with sedation or general anesthesia. In the operating day morning, we use CRW and we take a CT and have a fusion on the integral system. We plan the targets and trajectory. The special attention is paid to penetrate the brain when we are planning through a gyrus and not a sulcus when the trajectory is planned. And we should be aware of the veins in our entry point. And I forgot to mention, on the evening before DBS, the patient stops taking antiparkinson medication, which is gradually reduced 1 week before the surgery. After that, the second part starts in the operating room. Electrode placement is done awake in almost all patients in our clinic. But when the patient doesn't tolerate awake surgery, then we do the surgery in general anesthesia. We open burr holes in the frontal area with the coordinates of our planning and place the electrodes. Especially for subthalamic nucleus, we do MER, microelectrode recording, for physiological confirmation. As I said before, many centers doesn't use it anymore. In the studies, there is no big difference in the results. For GPI, we don't use in our hospital MER, microelectrode recording, but we also use macro stimulation for the side effects. We examine the patients perioperatively. And after electrode placement, I personally like to use O-arm to match the electrode with which we planned earlier. After we are sure about the placement, we close the wound and go into the second part of the surgery in the same day. In the second part of the surgery, the patient have general anesthesia, almost 30 minutes to place the battery and the extension cables. Then the procedure ends. When we talk about the electrodes, there are 3 brands of deep brain stimulation which are approved by FDA, about based on scientific and Medtronic. There are many variations of electrodes. And here you are Here you see in the first picture standard electrode with 4 contact in the left side. Recently we can use 8 contact, and at the right corner you can see the directional leads. That makes programming DBS easier to solve the problems of side effects. When we look at the batteries, there was just non-rechargeable one almost 10 years ago, and it has a maximum 5-year lifespan. But it can be changed patient by patient with the targets and amplitudes that they use. For the rechargeable battery, it's known over 15 years lifespan, but there could be problems, both of them. For example, patients with non-rechargeable batteries need more surgery as the battery will be depleted every 2 to 5 years. In rechargeable battery, some of the patients feel sad about this recharging process. Because it needs to be charged once a week or every day at certain times via remote connection, they feel like restricted during the charging process. In our clinic, we talk every detail with the patient and the patient caregiver. It's really important to decide the battery type. After surgery, if everything goes well for the first few days, we start to stimulate with the nodes of per-operative stimulations node. Day by day, we increase the amplitude at the outpatient clinics. We need at least 2 weeks to be in baseline of medications and stabilization. The stabilization period is characterized by a gradual adaptation of medication and stimulation parameters. That should be balanced. It's up to 6 months after surgery. And I want to remind, it has been also shown that a lower reduction in dopaminergic medications might also result in lower incidence of apathy and depression. And let's talk a little about the parameter settings in DBS. These are the typical stimulation parameters for each target. The amplitude is the main parameter used to control the intensity of stimulation. Pulse width refers to the duration of each electrical pulse delivered, and the efficacy of DBS is based on high-frequency stimulation. But in some circumstances, we can have benefits with lower pulse width and higher frequency without side effects. As I said before, there are many variations to try the best point without stimulation problem, without the side effects. But the main thing in here is the per-operative effectiveness notes about the contacts. Here you can see the monopolar and bipolar usage for the stimulation. When we come to the complications, no treatment in medicine is without risk, including medications. And it could be about surgery related, heart failure, or stimulation related. And brain hemorrhage is the most feared complication of DBS in general, but it could be small and asymptomatic, and it can also be symptomatic and present in a broad spectrum of symptoms varying from headache to hemiparesia. Additionally, there could be confusion, delirium, and hallucinations also. Stroke, deaths, and cardiac events are the general risks of every brain surgery, and seizure is very rare without any stroke or hemorrhage. As for heart failure-related complications, infection of the heart failure is most distressing heart failure-related complication of DBS in general. And it has been seen up to 15% in some studies. If the infection is superficial and there is no open wound, antibiotics alone may be sufficient. If there is a discharge on the wound side, for example, on the battery, it may be necessary to wash out the area. Depending on the situation, the battery or extension cables could be completely removed and wait until the infection is not observed. This is usually after 6 weeks of intravenous antibiotic use. And one of the most common problems is development of skin erosion over the extension cables, especially behind the ear. In this case, the exposed areas should be covered with skin revision and antibiotics should be used for a while. When we look at the stimulation-related side effects, these are temporary tingling in the face or limbs, a feeling or pulling in muscles, speech or vision problems, loss of balance, stimulation in the dyskinesia, hypophonia, or major stimulation-related side effect is at the level of the behavior. Mild changes in emotional and cognitive parameters can be frequently seen, and also there could be depression, mania, or psychosis rarely. These stimulation-induced side effects improve when the stimulation is discontinued, and when these are noticed, recurrence can be prevented by making the necessary settings in programming. When we look at each target side effects, you see the summary in this summary slide. And in SDN, tonic contraction and paresthesia with diplopia, you can see. In GPI, phosphones, nausea, and tonic muscle contraction. In VIM, ataxia, tonic contraction, and paresthesia, we can see in the patients. As Dr. Dilek states, these factors, but I want to remind, we should be aware of these predictive factors for adverse events. Behavioral instability, severe depression, cognitive impairment, levodopa resistant signs, dysarthria, dysautonomia, balance impairment, poor general health, brain atrophy is the main thing, is the most important thing, and elderly patients. Finally, let me remind you the most important thing about the success of the DBS is the reasonable expectations. DBS doesn't fully resolve all the symptoms of PD, ET, or dystonia, but it can decrease a patient's need for medications and can improve quality of life. Let's see some patients with DBS. Here, he was 72-year-old and has Parkinson's disease since 2010, and primary problem was bradykinesia and levodopa-induced dyskinesia and tremor. And we performed him GPI DBS in 2016. She was 77-year-old and she is the oldest one that I have ever done. She has Parkinson's disease since 2003. Primary problem was levodopa side effects, and we performed STN DBS in 2016. And she was 45-year-old and has PD since 2012. Primary problem was inability to walk due to freezing, and we have done GPI DBS to her. And the last case, he was 58-year-old and has PD since 2013. And at the beginning of this video, you see the patient at the day of operation, hours before the surgery, hours after the surgery. Primary problems were tremor, levodopa-induced, dyskinesia, bradykinesia, and we performed the GPI DBS in 2020. We see in that patient GPI as good as SDN in tremor control. Thank you for listening. I have to say honestly that Parkinson's disease, or you see it in the Parkinson's disease in these videos, it's not just about the improvement symptoms seen in these videos, like other movement disorders. Here we should stand on realistic expectations and talk to the patients every details. These are what I wanted to tell you today. Actually, there are more subjects to talk about DBS, but for today, we are at the end of the time of presentations, I guess, and we can move on to the question section. And here we can see from there in the chat side. Okay. And if there is any question, then we can have. I guess there is no question. And thank you for your attendance. for listening. If you have any question, you can write in the comments and we can answer you after the presentations.
And for getting certificate, you can fill a form below.
Okay, thank you so much.
Thank you.
Have a nice day.
Health is life. Life is feeling at peace and in safety. To dream again, to look to the future with hope, to be joined with your loved ones for years ahead. Life is feeling valued, feeling special, because your life is precious. Seeing the larger picture requires talent. Attending to the finer points calls for patience, and knowing that success is hidden in the details demands experience, while leaving behind a trace with every step requires leadership. We strive to see you smile. We gain strength from the happy tomorrows you share with your loved ones. We are the most trustworthy partner in health of every person whose life we touch. Value of seeing you sometimes give life a new greeting, or watching eyes open to life for the first time, or sometimes the hope and hearts looking to each other with love. With the responsibility given to us of being a global hospital, we meet each new day with equal enthusiasm. Through our accumulated knowledge, each year we nurse more and more people back to health. We stand beside you so that you can lead a healthy life. We understand you and share your language. We believe that spreading happiness requires courage. On the road we have set forth with this aim, we are proud to provide you with the very best and to grow with you. You are valuable to us.
Thanks, Memorial.
Спасибо, Memorial.
Шукран Memorial.
Mersi Memorial.
Faleminderit Memorial.
Grazie Memorial.
Çok sağ olun.
Memorial.
Memorial. Because your health